appreciated.
Great. Thank you.
So we're going to move on to the next session, Novel and Emerging Therapies in Treatment of Pancreatic Adenocarcinoma. And I'd like to welcome my co-moderator, Anirban Mitra. Anirban?
Thank you, Margaret. Thanks, Margaret. So welcome, everyone. So we have a really exciting lineup of 2 speakers for this session. Our first speaker today is Dr. Ghulam Abbas Manji, who's assistant professor in the Division of Hematology and Oncology and director of Pancreas Medical Oncology and Translational Medicine at the Columbia University Irvine Medical Center and their Pancreas Center there. Dr. Manji completed his fellowship in Hem-Onc at Columbia University. He is a previous Young Investigator awardee from ASCO, and he is pursuing several preclinical research initiatives in collaboration with colleagues at Columbia, including Ken Olive and others, in terms of identifying promising immunotherapy combinations. So we look forward to your talk, Ghulam. And just a reminder, again, the chat session is open, so please type in your questions and Margaret or I will ask those questions to the speakers at the end. Thank you.
I'd like to thank the meeting organizers for giving me the opportunity to review the current landscape of immunotherapy in pancreas cancer. These are my disclosures. The pancreas tumor microenvironment immunologically is considered a cold tumor, where only a subset of tumors are considered immunologically active. Although immune checkpoint blockade has changed the treatment landscape of other histologies, treatment of pancreas cancer with single agent PD-1 or CTLA-4 targeting agents and recently reported combination immune checkpoint blockade remain ineffective. The Canadian Cancer Trials Group tested combination chemotherapy with immune checkpoint blockade, which was reported at ESMO this year. The randomized phase 2 study assessed the efficacy and safety of gemcitabine and nab-paclitaxel either alone or in combination with durvalumab, which targets PD-L1, and tremelimumab, which targets CTLA-4. The study did not meet the primary endpoint of overall survival. Similarly, there was no statistical difference in progression-free survival or overall response rate. These results indicate that addition of immune checkpoint blockade to chemotherapy does not enhance chemotherapy in pancreas cancer. These figures have been borrowed from an excellent review on pancreas cancer and the tumor microenvironment by Dr. Lei Zhang and colleagues. As indicated in the figure, histologically, the tumor microenvironment of pancreas cancer is complex and contains multiple strategies utilized by the tumor to evade immune surveillance. Amongst these strategies includes a dense stroma, paracrine signaling between neoplastic and supporting cells, including cancer-associated fibroblasts, which help establish a tumor niche and help recruit immunosuppressive cells while utilizing mechanisms to exclude cytotoxic cells. The figure on the right depicts some of the pathways at play and the therapeutic strategies currently being tested to inhibit immunosuppressive mechanisms which target regulatory T cells, myeloid-derived suppressor cells, and chemokines, while on the other hand, strategies which enhance anti-tumorigenic activities such as enhancing antigen presentation. This talk will focus on a few of these pathways and highlight promising clinical trials which target them. Due to the time constraint, many equally important studies will not be discussed. Nonetheless, with a number of studies ongoing, it is an exciting time in pancreas cancer where the field is ripe for new discoveries in the clinic. Multiple lines of evidence suggest that pancreas cancer is not inherently resistant to immunotherapy. First, retrospective studies on resected tumors indicate that patients whose tumors express high levels of PD-L1 and low levels of CD4+ or CD8+ positive T cells fare worse than those whose tumors express low levels of PD-L1. Second, spatial distribution of cytotoxic T cells in proximity to cancer cells correlates with increased overall patient survival. Third, patients with microsatellite high tumors respond to immune checkpoint blockade. These observations suggest that the immune system has a role in influencing outcomes in pancreas cancer and it is likely that the highly immunosuppressive tumor microenvironment needs to be neutralized for immunotherapy to have an impact on efficacy. Identifying and targeting these key immunosuppressive pathways remains one of the key major challenges and a therapeutic opportunity in pancreas cancer. The 4 immunosuppressive mechanisms that will be discussed are CD40, adenosine, CXCL12 and CXCR4, and the MEK autophagy pathway. CD40 is a cell surface member of the TNF receptor superfamily, and the CD40 ligand, which is primarily expressed on T cells, interacts with CD40 on antigen-presenting cells, which results in upregulation of cytokines, antigen-presenting molecules, and co-stimulatory molecules, resulting in priming and activation. In a xenograft mouse model of pancreatic cancer, Dr. Bob Vanderheid's group demonstrated that treatment with gemcitabine nab-paclitaxel and an activating antibody targeting CD40 resulted in tumor responses. These responses were dependent on CD4 and CD8 cells, as treatment with neutralizing antibodies to these molecules dampened the effect. Within the KPC genetically engineered mouse model of pancreas cancer, combination therapy with the same regimen resulted in an overall survival benefit compared to chemotherapy and activating CD40 antibody alone. Given these and a multitude of other preclinical studies, this combination was pursued in the clinic. A phase 1b study in first-line stage 4 pancreas cancer was conducted to determine the safety, dose-limiting toxicities, and the recommended phase 2 dose of gemcitabine, nab-paclitaxel, APX005M with or without nivolumab. The interim results were presented at the AACR conference in 2019. The median follow-up at time of presentation was 32.2 weeks. At the time of presentation of the data, 13 of the 24 evaluable patients discontinued therapy due to an adverse event, of which 10 were deemed treatment-related, and 4 subjects had expired, 2 due to disease progression and 2 due to adverse events related to sepsis. In conclusion, the investigators should be commended for completing a trial that was rapidly accrued over multiple sites based on extensive preclinical data. The challenges facing ahead include the significant proportion of subjects who discontinue treatment due to adverse events. Will continued experience with treatment of patients with APX005M improve the management of symptoms such that the treatment is better tolerated? Additionally, will the response rates in a larger phase 2 cohort persist? And most importantly, will treatment benefit last? The phase 2 study is now complete to enrollment, with results expected in 2021, which are eagerly awaited. Celiprolumab is another agonistic CD40 antibody which is currently being tested in first-line stage 4 pancreas cancer in combination with gemcitabine, nab-paclitaxel, and atezolizumab. Preliminary results are expected to be presented at SITC within a few weeks. The next immunosuppressive pathway to be discussed is that of adenosine. Under physiological conditions, adenosine serves as an immunoregulatory molecule to protect normal tissues from uncontrolled inflammation. Extracellular ATP released after neoplastic cell death is enzymatically converted to adenosine via CD39 and CD73. Adenosine binds to its receptors on immune cells and results in attenuation of protected immune cells, including T cells, NK cells, and dendritic cells, and by enhancing the suppressive capacity of regulatory T cells and myeloid-derived suppressor cells. Dr. Chiarella from Dr. Anil Rutzi's group at Columbia University demonstrated increased expression of CD73 in pancreas KPCY cell lines compared to that of wild type. Analysis of the TCGA pancreas cancer cohort indicated an association between high CD73 expression and poor survival. Lastly, patients whose tumors exhibited a KRAS mutation and increased CD73 expression fared worse compared to those whose tumors either expressed low levels of CD3 and or had no mutation in KRAS. Collectively, these and other studies suggest a role of CD73 and the adenosine pathway in cancer immune evasion. Results of the phase 1 study testing combination FOLFOX and AB928, an inhibitor of the adenosine 2A and 2B receptor, was reported at the AACR conference this year. The combination was well tolerated, and encouraging disease control rate was observed even in the third-line setting. Multiple ongoing early phase clinical trials combining gemcitabine, nab-paclitaxel, immune checkpoint blockade, and agents targeting CD73 and or the adenosine receptors are ongoing. Of note, 2 patients with pancreas cancer treated with oleclumab, an antibody targeting CD73 in combination with durvalumab without chemotherapy, had remained on study for 140 and 182 days at the time when the study was presented in 2018, suggesting some activity. The CXCR4-CXCL12 axis came of interest in pancreas cancer after a preclinical study in KPC mice by Doug Fearon's group was reported and demonstrated tumor stabilization with AMD 3100, an inhibitor of CXCR4, in combination with anti-PD-L1 antibody. In a short 6-day experiment, tumors treated with this combination exhibited a 15% tumor response while survival was not evaluated. This data resulted in 4 clinical trials, some of which have been complete and some of which are ongoing. In an effort to test whether this combination resulted in a survival benefit and whether addition of chemotherapy enhanced efficacy, we performed a randomized 7-arm study in KPC mice testing for survival. We found that addition of chemotherapy to CXCR4 inhibition and PD-1 blockade enhanced tumor stabilization and resulted in a 50% extension in survival compared to chemotherapy alone. This arm is represented by dark blue on the left. Inhibition of CXCR4 in combination with PD-1 blockade without chemotherapy did not result in an increased overall survival. This arm is depicted in red. Consistent with our preclinical findings, pancreas cancer patients treated with pembrolizumab in combination with BL8040, a CXCR4 targeting peptide, in the second-line setting resulted in a median overall survival of only 3.3 months and a response rate of 3%. The clinical trial subsequently included a cohort which added 5-fluorouracil and liposomal irinotecan in the second-line setting with improved disease control rates, which was predicted in our preclinical study. In order to interrogate the effects of the therapy on the tumor microenvironment, we embarked on a short-term biopsy necropsy study in KPC mice over 6 days. Multiplex immunofluorescence on the paired biopsies demonstrated a near 4-fold increase in the CD8 to FOXP3 ratio. In collaboration with Dr. Raul Rabadán at Columbia University, we demonstrated that the triple therapy resulted in a change in the spatial distribution of cytotoxic T cells, bringing them closer in proximity to cancer cells. The triple therapy is depicted in blue on the right. Based on these preclinical studies, we are pursuing a phase 2 clinical trial testing the safety and preliminary efficacy of motixafortide, formerly known as BL8040, cemiplimab, an antibody targeting PD-1, gemcitabine, and nab-paclitaxel in patients with metastatic pancreas cancer in the first-line setting. The first 10 patients will undergo required pre-treatment and on-treatment biopsies for correlative analysis. The clinical trial is active for accrual. The last pathway to be discussed is one where Drs. Channing Durr and Martin McMahon simultaneously reported addiction of autophagy in KRAS-mutated cancers and demonstrated that co-inhibition of the MEK and autophagy pathways resulted in tumor shrinkage and extension of survival in xenograft and PDX mouse models. These results led to 4 ongoing clinical trials combining hydroxychloroquine with various inhibitors of the MEK pathway. Separately, earlier this year, Dr. Alec Kimmelman's group in an elegant study demonstrated MHC class 1, that MHC class 1 was found enriched in lysosomes and that inhibition of autophagy by chloroquine restored cell surface expression of MHC class 1 molecules. Further, combination therapy with chloroquine and immune checkpoint blockade resulted in tumor control. We recently reported a case of a 61-year-old male with high mutation burden, recurrent KRAS-mutated duodenal adenocarcinoma who was initiated on compassionate use cobimetinib and hydroxychloroquine after failing all standard of care therapies, including nivolumab. He clinically improved at CT and CT scan of the chest at 4 and 10 weeks after initiation of therapy demonstrated a response and a rapid decline in plasma CEA. He subsequently had difficulty tolerating therapy and had multiple treatment interruptions. CT scans 4 months after initiation of therapy indicated disease progression. Based on this clinical report and discussed preclinical studies, we proposed a phase 1/2 clinical trial testing combination therapy with cobimetinib, hydroxychloroquine, and atezolizumab in KRAS-mutated adenocarcinoma. The clinical trial is currently accruing patients. In summary, immune checkpoint blockade is not indicated for the majority of patients with PDAC, and addition of chemotherapy does not yield any added benefit. APX005M in combination with chemotherapy and nivolumab has shown promise, but with significant treatment-related adverse events. Final results of the study will also address the durability of the response. Anecdotal clinical reports and significant preclinical data suggest a role of the adenosine pathway, which is being interrogated in multiple clinical trials. Preclinical and preliminary clinical data indicate that chemotherapy will likely be needed in combination with CXCR4 inhibition and immune checkpoint blockade for efficacy. Lastly, combination of immune checkpoint blockade with dual inhibition of the MEK and autophagy pathway has rationale and is worth pursuing in the clinic. I would like to acknowledge all the patients and their families for participating in clinical trials, all my collaborators and members of the laboratory who conducted the experiments, and to the Velocity Research Grant at Columbia University and the ASCO Young Investigator Award, which led to funding of the preclinical and clinical studies discussed herein. I thank you for your attention.
Thank you so much, Gulam. That was great. Really appreciate it. So again, reminder to please type your questions in the chat and I'll read them out. So we have one question here from Paul Campbell. When triple treatment, including CXCR inhibitor, results in decreased proximity of cytotoxic T cells to tumor epithelia in murine PDAC, do you think this is a result of simply more T cells and their activation, or greater inherent motility of these cells, or a modulation of the ECM? Question. You're muted, Gulam.
Sorry about that. No, that's an excellent question. So we actually went ahead and did a sophisticated analysis where we controlled for the number of cells. So there are cells that were, that we haven't shown the data, but there was increased apoptosis in the neoplastic cells. So that was controlled for. Regarding, we think that it's a motility issue, but we're actually looking at, in the experiments, we're designing organoids, and then looking at autologous co-culture experiments with PBMCs, and then doing motility experiments to try and really see whether it's a motility issue or not. But studies ongoing, we'll see.
Thanks, Gulam. I have another question from Vincenzo Nasca. Thank you for the great talk about the choice of immunotherapeutic drugs for testing. There have been recent single-cell RNA sequencing work highlighting an exhausted phenotype of T cells and other checkpoint blockade molecules increasingly represented in the pancreas cancer microenvironment. That is to say, shall we move on from the classical anti-PD-L1, PD-1 to novel immunotherapeutics such as TIGIT or others?
Right. The TIGIT molecule is being, or the target is being tested in another combination study in the Morpheus platform. So we'll see what that really shows. But the thing is that with pancreas cancer, I don't see it as one disease. I think that there are multiple different major immunosuppressive pathways. And then really we need to look at each individual patient and see which of these immunosuppressive pathways are dominant in these specific patients, and then really design or think about those specific targets that need to be challenged. And then there's probably, it's a fluid mechanism where targeting one immunosuppressive pathway will probably increase or make the other immunosuppressive pathways more important.
And then I think we probably should move on. These are great questions. We'd love to keep them going. But
back to you, Margaret.
Yeah, maybe Ghulam, you could go into the chat and answer any others privately.
Thank you.
Our next speaker is also probably doesn't need much introduction. He's a legend in GI oncology. Dr. Jim Abruzzi is a very dear longtime friend and colleague. He spent the first part of his career at MD Anderson, where he was chair of the Department of Gastrointestinal Medical Oncology and Digestive Diseases. And then he subsequently moved to Duke, where he is chief of the Division of Medical Oncology. Dr. Abruzzi, please take it away.
Good morning, and welcome to the American Pancreatic Association session on novel and emerging therapies in the treatment of pancreatic cancer. My name is James Abruzzi, and I want to thank the APA leadership for inviting me to speak to you today. This slide depicts the outline of my presentation. We will start with a review of the importance and diverse biologic implications of oncogenic KRAS mutations in pancreatic cancer. I will then discuss emerging data on targeting the codon 12 G12C mutation with the novel drug sotorasib, or AMG 510. We will then briefly review emerging data on potential actionable targets beyond KRAS and the early results of targeting these alterations in the context of recent precision medicine trials. The final part of the talk will then focus on the subset of patients with KRAS wild-type pancreatic cancer. Based on the detailed pathologic studies of Dr. Ralph Ruben and colleagues, and more recent genetically engineered mouse models of pancreatic carcinogenesis, it is well established that oncogenic mutations in KRAS are sentinel early driver events in pancreatic carcinogenesis. Subsequent events, including loss of tumor suppressors, including p53 and SMAD4, contribute to the aggressive natural history of this disease and impact multiple aspects of its biology. Mutations in KRAS activate the RAS, RAF, MEK, ERK signaling pathway, and many preclinical studies have demonstrated that interfering with KRAS signaling impacts cellular proliferation and survival. Based on these studies, KRAS was identified as an important, though until recently largely undruggable, target for therapeutic development. In addition to alterations in cell signaling, mutated KRAS contributes to the extensive metabolic changes that are characteristic of pancreatic cancer. These effects include increased glucose uptake, the Warburg effect, differential channeling of glucose intermediates, reprogramming of glutamine metabolism, and increasing autophagy, as well as increased micropinocytosis. The epithelial changes engendered by mutated KRAS, along with subsequent genetic events, also contribute to the development of the complex stromal changes that characterize the tumor microenvironment of pancreatic cancer. This slide depicts data from the Duke Molecular Registry of Tumors over the past 3 years. As you can see, the most common KRAS missense mutations are at codon 12 and include G12D in 40% of cases, G12V in 35% of cases, and G12R in 15% of the cases tested. The missense mutation G12C, present in only 2% of this series, is important because this specific KRAS missense mutation is druggable using the novel agent sotorasib. However, there is a subset of patients with no detectable alterations in KRAS, depicted here in red, that we will examine further in subsequent slides. The activity of sotorasib in non-colorectal GI cancers is outlined in this slide as recently published in the New England Journal. As you can see, there appears to be some modest stabilization of disease in pancreatic cancer patients. However, a more extensive experience with sotorasib in pancreatic cancer will be needed to understand whether this agent contributes to clinically meaningful survival improvements for pancreatic cancer patients. Our limited ability to identify cytotoxic drugs broadly active in pancreatic cancer has stimulated a concerted effort to identify patient subsets that are responsive to therapeutics that can target molecules that directly contribute to the pathogenesis of pancreatic cancer. Such targets would include cancer cell targets such as KRAS, or increasingly targets in the microenvironment. Validating and employing targeted therapies for pancreatic cancer is not a simple undertaking. As outlined here, there are a number of potential obstacles. First, acquisition of sufficient tissue. Second, establishing robust assays to identify targets. Third, rapid turnaround of the results. And fourth, application of the therapy to patients. The rationale for targeted therapy in pancreatic cancer is well established. Pancreatic cancer is highly heterogeneous. The impact of cytotoxic therapy is modest. Immunotherapy has not yet proven effective, and therefore identification of responsive patient subsets may be the best immediate way forward. Many investigators have pointed out the numerous potentially druggable targets in pancreatic cancer. This is a slide from Andrew Biankin from the University of Glasgow and depicts some of the targets and agents with potential efficacy. Included in this list are frequent alterations in DNA repair enzymes, confirming activity to platins such as cisplatin and oxaliplatin, as well as PARP inhibitors. Recognition of these therapeutic targets has led to a number of trials that examine the impact of targeted therapeutics on the management of patients with pancreatic cancer, including studies in the United States, Canada, and Australia. I wanted to highlight one such example from the Pancreatic Cancer Action Network published by Dr. Michael Pishvayan in 2018. This slide shows the consort diagram for the Know Your Tumor program published by Dr. Pishvayan. What is apparent from this diagram is the complexity and challenges inherent in translating genomic findings, genomic testing, actionable target identification, therapeutic agent acquisition, and treatment of patients with those agents. In many instances, oncologists did not initiate therapy with a recommended targeted agent. A more detailed look at the impact of this program demonstrated that of the 1,020 patients consented, 640 patients completed testing and reports were generated. In 126 patients, oncologists used the reports to guide therapy. In 35 of these 126 patients, a highly actionable therapy was identified. Of those 35 patients, survival was improved when the actionable match therapy was employed, with a PFS of 4.1 months. And this is in comparison to a 1.9-month PFS when a non-matched therapy was employed. Thus, while only a subset of patients enrolled in the program were able to ultimately benefit, the study suggests that the identification of a specific actionable target and application of an appropriately targeted therapy can lead to improved outcomes relative to non-targeted options. I would now like to discuss some of the evolving data relevant to the subset of patients with no apparent KRAS mutations. As you can see, various data sets fail to identify KRAS mutations in approximately 3 to 14% of patients. In my own experience, I think the percentage of KRAS wild-type patients is closer to 3 to 5%, with some of the variability depending on the quality of the specimen submitted and the depth of sequencing. Some studies have also described considerable heterogeneity within pancreatic cancer specimens. This slide summarizes some of the key published literature on wild-type KRAS pancreatic cancer and highlights the timeline and key observations. The work by Aguirre et al. Used TCA samples and identified 10 patients without KRAS mutations. Genetic analysis demonstrated that these patients were enriched for germline alterations in familial risk genes and the presence of alternative oncogenic drivers affecting primarily the RAS MAP kinase pathway. Two subsequent patients in 2018 and 2019, published by Heining and Jones respectively, identified a subset of wild-type KRAS patients with rare NRG1 fusion events. As we will see, these rare alterations are therapeutically important. A small series from the University of Pennsylvania describes some of the demographic and prognostic implications of the lack of KRAS mutations in pancreatic cancer. These observations are summarized on this slide, and importantly suggest that wild-type KRAS cancer may be associated with age, that is more common in younger patients, and survival times in the KRAS wild-type population may be slightly longer than patients with KRAS mutations. However, this is a small, single-institution retrospective study, and additional data from larger databases are needed. Over the next few slides, we will examine the genetic heterogeneity of KRAS wild-type pancreatic cancer. Depicted here are key observations from the Aguirre et al. Study that identified alternative oncogenic alterations in genes affecting the RAS MAP kinase pathway, alterations in germline oncogenes, as previously mentioned, amplifications in genes such as HER2, and increased signaling through the mTOR signaling pathway. This slide summarizes the molecular alterations in KRAS mutant and KRAS wild-type pancreatic cancers ages 24 through 49. Activating KRAS mutations and oncogenic gene fusions involving NRG1 in 3 patients and RET in 1 patient were mutually exclusive. In this series, inactivating p53 mutations were frequently coincided with KRAS mutations, but were absent in KRAS wild-type tumors. Again, these are data from the Duke Molecular Registry of Tumors that again speak to the marked heterogeneity of alternative oncogenic events in patients without detectable KRAS mutations. In this series of 9 wild-type KRAS patients, inactivating mutations in p53 were indeed documented. Looking at the data available from the large GENIE database, the spectrum of alternative mutated oncogenic drivers is again demonstrated to be quite heterogeneous and includes mutations in p53, BRAF, IDH1, and GNAS, among others. It is important to note that in the context of BRAF and IDH1 mutations, these may in fact be actionable alterations that are important to recognize in this subset of patients with wild-type KRAS genomic status. As noted previously, NRG1 fusions are rare but targetable alterations in KRAS wild-type pancreatic ductal adenocarcinoma, and for this reason are important to identify. This slide summarizes a model for how NRG1 fusion proteins harboring an EGF-like domain bind ERB3, which subsequently heterodimerizes with ERB2 and activates oncogenic levels of RAS effector signaling pathways. This oncogenic driver event can be potentially inhibited by anti-ERB3 antibodies or a pan-ERB3 inhibitor such as afatinib. Afatinib is a second-generation ERB inhibitor that irreversibly binds to an intracellular tyrosine kinase domain. Most specifically, afatinib binds to ERB1, ERB2 or HER2, and ERB4 receptors. To summarize, KRAS wild-type pancreatic cancer is a rare but important subset of patients with pancreatic cancer. The frequency may be more common in younger pancreatic cancer patients, may confer longer survival, and there is the potential to identify actionable therapeutic targets. Therefore, the molecular testing strategy used to molecularly characterize somatic alterations in pancreatic cancer should be capable of identifying these alternative oncogenic driver events, particularly rare gene fusions affecting NRG1. Thank you very much for attending this virtual event, and I will be available to answer any questions.
Thank you, Dr. Abruzzi. That was great. I have a quick question. I'm glad that you brought up the issue of having enough tissue to do molecular profiling. That's a really recurrent theme. And in my experience, about 50% of our patients have diagnostic biopsies that are not analyzable. And so I wonder if there is, you have a protocol or something set up at Duke to improve or optimize the collection of sample so that we do have enough tissue.
Yeah, thanks, Margaret. That's a great question. I have to say we do not have a formal process for trying to acquire additional tissue. Certainly, if we think it's critical and we can identify a lesion that can be safely targeted for rebiopsy, or prospectively plan to do a core biopsy rather than just a fine needle aspiration. That's certainly what we do. I have to say, increasingly, I have been, in some cases, even getting parallel circulating tumor DNA assays performed on our patients, where I'm concerned, especially for someone referred from another center, that the tissue may be inadequate for more comprehensive testing. I think that the utility of that strategy with circulating tumor DNA is still, in my experience at least, a little bit unclear, as it appears the amount of circulating tumor DNA in pancreatic cancers may be somewhat less than that of other disease states, even in the metastatic setting. But it's early yet, and I think we have a lot more experience to really understand how useful that strategy is going to be.
We have a question from the chat from Julia Meyerly. In KRAS wild-type cancers, what are the major drivers of oncogenesis?
So as I think I tried to show, it's actually very heterogeneous. Eileen also went into this. We look for particularly actionable alterations such as fusion events, and I think if one is faced with a wild-type KRAS wild-type cancer patient, one thing I really look at is, what are the available platforms to do the testing? Does the platform we're using to look for fusions involve RNA-seq, or are we going to miss some of these very rare alterations? But you'll see a variety, a very heterogeneous number of alterations. The fusions probably being the most targetable, but as I think we were able to show, there are going to be alterations in BRAF, occasionally IDH1, and some other potentially targetable abnormalities.
So question from Mahendra Singh. A subset of pancreatic cancer patients, about 20%, do have MYC amplification. Wondering what is the percentage in patients with KRAS wild type, and how do they respond to therapies?
It's a great question. We know that many, if not most, KRAS mutant patients have MYC amplification. Ron Evans and colleagues at Dan Von Hoff have studied the implications of MYC amplification as a strategy to try to identify targets for novel therapeutics in pancreatic cancer. The problem has been that that group has targeted primarily downstream events. And the results of those studies, I think, while preliminary and in some cases intriguing, have just not been yet studied enough patients to really know if that downstream MYC strategy is viable. Targeting MYC as a transcription factor is still, while there are some reported agents, it's still a challenge, as is targeting any transcription factor. It's just a difficult sort of druggable target. So I don't know of any data specific to the KRAS wild type subset. It could be a very interesting question, and I'm sure it's testable, but I just am not aware that the Von Hoff, Ron Evans group have really tackled that at this point.
Thank you. It looks like we're ending up pretty much on time. Anirban, do you have any last words?
Oh, that was fantastic. Thank you, Jim, and thank you, Ghulam, for that overview. And again, thank you, Eileen, as well, for starting out our second and last day of the APA today. I don't have any other questions. Margaret, you want to bring us home?
Thanks, Anirban. I think we can turn it over. The next session is the Frank Brooks lecture, and I'll turn it over to my colleague, Dr. Aida Habtizian, to do the introduction.